Hi, I'm Leslie Wyers. My connection to pediatric transplant is that I am a mom of two children who have kidney transplants. My son Logan was transplanted 11 years ago, and my daughter was 9 years ago, both at the Children's Hospital of Philadelphia. I am the co-chair of IROC's Community Engagement Work Group and previously served on the UNOS Patient Affairs Committee. It is my honor to welcome Dr. Sandy Amaral. She is the medical director of the kidney transplant and hand transplant programs at Children's Hospital of Philadelphia, also known as CHOP. She leads the Kidney Transplant Transition Clinic program and is the founder and director of the Chopped Cooking Camp for Youth with Kidney Disease. And she is an associate professor of pediatrics and epidemiology at the Perelman School of Medicine at the University of Pennsylvania. Dr. Amaral is a staunch public policy advocate for children and young adults with renal disease and their caregivers. And I'm just going to put a plug in that she is a hero for our family, as her grace and patience at the start of our kidney journey was a blessing. And we've been with her for over a decade, and she is that calm when our storm is rising. So I am just beyond honored to welcome her to this presentation of, let me get the total presentation of Kidney Transplant Health for All. Dr. Amaral.
Okay, excellent. Thank you so much for the kind introduction. Today, we're going to talk a little bit about what the kidneys do and why I chose to be a nephrologist, indirectly, but Kidney 101. And then I'll talk a little bit about why kidney injury happens in transplantation, and then a couple things that we can do to try to keep our kidneys healthy and prevent injury. So first, Kidney 101. So let's see if you can see my arrows. So every single day, your kidneys work to clean or filter your blood. And it's over 50 gallons of blood that the kidneys see every day. And the blood enters the kidneys from a large artery from the heart. And blood passes through over 1 million tiny little filters in each kidney. And then gets rid of waste products, which is placed in your urine. And then the urine passes through these tubes called your ureters, and the urine gets stored in the bladder. And then the clean blood goes back to your bloodstream through the veins. And once the bladder's full, it empties and urine passes out. And of the 50 gallons of blood that are filtered daily, only about a half a gallon ends up as urine, and the rest stays in your body. So I like, when I'm teaching residents about kidney function, I sort of made up my own acronym that I think about, the ABCDEFGs. And so this is what that stands for: anemia, bone disease, cardiovascular disease, diet, electrolytes, fluids, and growth. So you'll see that the kidneys have many, many diverse functions, and I'll talk a little bit about why and how. So first, the A is for anemia. So the kidneys produce this hormone called erythropoietin. It tells the bone marrow to make red blood cells, and the red blood cells are what we need for oxygen in our blood, and the red blood cells use iron. And so often people with kidney disease will end up with anemia and iron deficiency because the signaling is disrupted. So B is for bone disease. And I'm not going to give you like drill down on this too much. I just really want to give you a general overview. But we need calcium and phosphorus for our bone development. And so kidneys help our bodies to absorb the calcium and get rid of phosphorus. And that absorbs calcium too. And the kidneys are involved in signaling our gut, our intestine, and our bone, and our parathyroid gland, these other glands that we have. The kidneys are involved in signaling how much or how little for the body to get rid of. And so again, if the kidneys aren't working well, this signaling is disrupted. And so our calcium levels can be off, and our bone growth and development can be off. Cardiovascular disease and hypertension are actually the biggest things that we worry about in terms of kidney disease and complications. And blood pressure is the result of your cardiac output, which is the volume of blood that leaves your heart and goes to the kidneys. and your total peripheral vascular resistance. And this is like the squeeze. So if you think of like a garden hose, if it's fuller, that's equivalent to more cardiac output. And if it's like a really tight squeeze, then that's more peripheral resistance. And in kidney disease, fluid overload or salt retention make us hold on to water and increase your cardiac output, and that would increase your blood pressure. And if you have increased waste products and calcium phosphorus, these things affect our blood vessels and make them stiffer, and that increases the tone or the vascular resistance. So those problems increase our blood pressure. The kidneys also have receptors in them that sense changes in renal blood flow. So their job is to clean the blood. And if they're not seeing as much fluid come down after, from the heart down into the kidneys, they might squeeze down to make sure that there's enough blood to go to the heart and the brain and other organs. And some of this is regulated by a hormone called renin that comes out of the kidney and gets activated. And so the kidneys have to do with blood pressure in that way as well. There are also receptors for volume and salt in other major blood vessels and in the heart. So all these things act together. And if the kidneys can't respond appropriately, you might end up fluid overloaded, or you might have kidney injury. If the kidneys have scarring or damage or inflammation, any of these things can disrupt all these signals. So I mentioned the stiffness of the blood vessels. And so you can see in this cartoon, the top column, this is normal renal function and normal cholesterol, and really no smoking, it should be. But in general, people, if people are smoking or they're aging, these are the things that might a little bit of plaque build up. This is what it might look like normally. But in a patient with kidney disease, these waste products and the phosphorus and some acids and inflammation markers, these things make atherosclerosis or those plaques build up even more. And this can happen even in young people. So that's why we worry so much about heart disease in our kidney patients. So one thing that I do want you to leave with is knowing what is a normal blood pressure. So for children, it's different than adults, and there were some revised guidelines in 2017. So if your child is 13 or older, normal blood pressure should top number less than 120 and bottom number less than 80. Traditionally, blood pressure less than the 90th percentile for age, height, and gender is considered a normal blood pressure. If it's between the 90th and 95th percentile, it's pre-hypertension, and if it's above 95th, it's hypertension. There have been studies in children with chronic kidney disease that suggest that if we're targeting the 50th percentile, that's actually better and may make your progression of chronic kidney disease slower. So we look at these charts especially for the kids under 13, and we say, well, how tall are they and how old are they, and is it a boy or a girl? And then we look on these charts and we say, what's a normal blood pressure for them? So if you're confused, or if your primary care doctor or a healthcare transplant provider is thinking that your blood pressure or their child's blood pressure isn't well controlled, you should really ask them what they're targeting, because the estimates, if they're targeting 50th percentile, that's really good, the type blood pressure control, but it may be much lower than you would think would be normal. So now I want to go on to D and E and F, and these things kind of go together. It's diet, electrolytes, and fluids. And so I talked about, we all have pre-transplant, but most people are born with 2 kidneys. Each kidney has about 1 million filters that clean the blood. And this is kind of a schematic of the kidney. There's the cortex on the outside, and the medulla is this part. And then even going down further, like at the microscopic level, we have parts of the kidney that are called the glomeruli, which are the filters. And then we have these tubules that you can see why they're called that, right? They're kind of tubular. And you don't need to know a whole lot about this part here. It's the glomeruli, the filters, And this part is the tubules. And you can see in this diagram all these things that are going in and out, and they're kind of like chemistry experiments. So the tubules tell us what to hold on to and what to get rid of. And they balance a lot of things like calcium and sodium and phosphorus. And that's why all these things are affected when the kidneys aren't working. So usually when there's a problem with kidney filters, which is the glomeruli here, people have trouble getting rid of things. So they can't get filtered out. So you may have high levels of phosphorus or potassium or proteins or sodium in your blood. You may not be able to get rid of water. Typically when people have problems with the tubules, that's where things don't get reabsorbed. So you tend to lose a lot of things. So sodium and phosphorus, all that stuff ends up in your urine. So you actually may need supplements. So whether something is too much or too little or just right really depends on the individual and the type of kidney problem they have. So a lot of our patients end up meeting with a dietitian to figure out what's the right diet and fluid regimen for them. And then the last part of the ABCDEFG part is growth hormone, growth. So this one was a little hard. I had a hard time finding kind of a simple picture, but this was the most simple that I could find. So kids with kidney disease often don't grow well, and this is because growth hormone is released from our brains, from the anterior pituitary gland, secreted and goes to the liver and the bone, and then this insulin-like growth factor is gets stimulated in different parts of the kidney. And again, then you have effects on calcium and phosphorus and all these other things. So there's a lot of interactions here. In impaired kidney function, this signaling does not happen normally. Also, there's inflammation in the body, and these toxins and all these other things also affect growth. So now you know kind of overall ABCD, EFG of the kidney and why, what the kidneys do. But why does this matter for someone that has kidney transplant? Excuse me, non-kidney transplant. So what happens after solid organ transplant? So one of my colleagues, Rebecca Rubner, who used to be, who trained at CHOP with us, she did a really nice study of national data among 16,000 pediatric solid organ transplant recipients. You can see there were half of them were liver transplant recipients, a third heart, a few lung, and a few intestine. And she followed the data, followed kids from for about 6 years, and it ranged from like 2 to 12 years. Among all those 16,600 children, only 426 developed end-stage kidney disease. So only 3% needed dialysis or transplant. So that's a good thing. But this is just catching the tip of the iceberg, right? This is just the patients that ended up needing dialysis and transplant. And we don't really know how many transplant recipients have some degree of kidney dysfunction. And that's really, those are the people that we want to make sure that they don't reach dialysis or transplant. So this was a 20-year study, and she did compare the rates of kidney disease by organ type. Did find that lung and intestine had greater risks of kidney disease than heart, lung, or liver. And some of this is related to some of the treatment and management for those organs being a little bit more high risk. So, you know, why do the kidneys get injured in transplant? Sometimes people have pre-existing kidney disease. Our measurements of kidney disease are often affected by muscle mass, and a lot of transplant recipients have pretty low muscle mass before transplant. So if we're not really paying attention, we can miss that kids have kidney disease before transplant. Other diseases in children also affect the kidneys. So we have lots of diseases that affect both the liver and the kidney, for example. Also infections, whether it's a bacterial or viral infection, that can cause inflammation in the kidney, certainly urinary tract infections. Medications, so tacrolimus, a calcineurin inhibitor, is a known risk factor for kidney injury. Unfortunately, it's the best medication that we have to prevent rejection, so most of our patients are on it. In addition, diuretics, a lot of particularly heart and lung patients, sometimes liver patients are on Lasix and things like that. That keeps you drier. So in some instances, that's going to put you at more risk for dehydration. If you have an infection that causes sepsis, you might have just blood flow that's not really going to the kidney because it's trying to support the blood pressure in the brain and the heart. And that can cause kidney injury as well. And then other conditions that you can get after transplant include diabetes and high blood pressure, which can be partly from the TAC, from steroids. If you have a family history, that'll exacerbate the risk. So what can we do about it? I would say be knowledgeable. Know your child's results, ask to see, the labs. I know many of you are very cognizant of that, and you look at, EPIC or whatever EHR you have. So, blood sugar, cholesterol, what's the blood pressure? Like I said, it's not always obvious that it may not be normal. In terms of kidney function, we measure creatinine, and that's used to estimate kidney function. It's a waste product that is produced from wear and tear on the muscle. So like I said, if someone's more muscular, they might have a higher creatinine. And sometimes we'll see people's creatinine jump a little bit, particularly in boys when they go through puberty and their muscle mass is increasing, and that can be normal. So it's important to kind of the physician will usually look at trends. And if your muscle mass is really low, your creatinine may be really low, and that may be masking kidney dysfunction. Cystatin C is another measure of kidney function that we use that's from a protein that isn't affected by muscle mass as much. And glomerular filtration rate is the term we use to see how your kidneys are doing. It usually goes from 0 to 100%. And the calculation estimates, exactly what your kidneys are filtering. But it's really like an estimate. It's not very precise unless you're doing some sort of measured test with an IV and contrast and everything. I did put a link in here to a GFR calculator. If you're motivated and you really want to know, you can go to this website from the National Kidney Foundation and put in your child's creatinine and cystatin C, their height, their BUN, and their gender, and it'll calculate for you what the result is. And I would say discuss results with the healthcare team. It's really hard sometimes, you might see like a red arrow going up, but it doesn't really mean anything. So make sure that you're going over it with someone that can interpret it for you. In terms of the results from that GFR calculator, in general, 90 and above is pretty normal. It can be stage 1 kidney disease if you have some other things going on. Around stage 3, that's like moderate kidney disease, like a kidney function of about 30 to 59%. Usually in that range is when people may need some medications or adjustments to their diet or fluids. And then severe loss is considered a GFR less than 29. And usually patients around this time should start having discussions about transplant or dialysis with their providers. It doesn't always mean that they need transplant or dialysis. It really depends on the kind of kidney problem they have. Oops, sorry. But it's better to discuss it early than late. And so we definitely recommend sort of starting discussions around time. In terms about prevention, so I mentioned that illnesses and dehydration, sepsis, all those things can contribute. So I would call healthcare team with any illnesses, especially those that lead to vomiting or diarrhea. You want to prevent dehydration. If you're on diuretics, you may need to reduce the doses or stop them. Similarly with blood pressure lowering agents. So it's always best to talk to the team and let them know what's going on. Also, if you have an infection, it's better, to get treated promptly. So, I say when in doubt, make sure that you call the healthcare team to discuss it. And if the child's very stable, but you're just concerned about the kidney function, it's reasonable to ask, what are my other treatment options and what can I do? You are your child's best advocate. So healthy lifestyle is also an important component of preventing kidney injury. The most common reasons for kidney disease in adults are diabetes and hypertension. And so regular exercise is really important. I know Dr. Kogan's going to talk to you about that. A balanced diet. I'm not going to go into that too much because I think that in general, we should all have whole grains, fruits and vegetables. But in terms of what your child needs for fluids and growth and calories and whether they need more phosphorus or less phosphorus, all those things are very specific to the child and should be really reviewed with a dietitian ideally. I also would, I want to emphasize that stress reduction is really important, and sleep. Stress, increases our blood pressure, and kids have a lot going on. So the more that we can help support them having a healthy daily life, that's tremendously important. I will talk about sleep again in just a sec. When they're older, in adolescence, smoking, alcohol use, all those things contribute to kidney injury and are bad for our cardiovascular disease and all those things. Also getting annual physicals, having a primary care pediatrician, somebody else to lay eyes on your child rather than the transplant provider who sometimes gets tunnel vision, and getting vaccines and using infection precautions are all good measures. I do want to stress that sleep is really another vital sign. So we did a study that was recently published, and we did survey measures with 212 parents and children with the children had kidney disease. And we did lots of measures: anxiety, depression, life satisfaction. And one of the number one predictors that the scores were going to be lower was if the parent reported that the child had sleep problems. This really was strongly associated with increased depression, increased anxiety, more fatigue, lower life satisfaction. And among 3 pediatric cohorts from the NIH with over 1,000 children that did not have kidney disease, children's sleep quality was significantly associated with lower levels of stress, better general health, and it predicted higher levels of satisfaction in life, even years down the road. And so this is just a table to remind us how much sleep kids actually need. It's really a lot. So a teenager should be sleeping 8 to 10 hours. So I know it's so hard, and lots of people are doing different advocacy to change school hours and things too. So in summary, the kidneys have lots of important functions. Stress on the kidneys is common among organ transplant recipients for many reasons. I think you got to keep up with your doctor's appointments, get labs regularly with the transplant team, make sure you're checking or picking up problems early. Practice preventive care through well checks with the primary physician. It's another person that can take, can take a look. Promote a healthy lifestyle for your child and your whole family. The more that you're modeling healthy behavior, the more your child is likely to model healthy behavior. And I would say know your child's numbers and your numbers, especially if you were a donor. I do have some references from the National Kidney Foundation and the NIDDK. Those are great websites to check. They're very reliable and have accurate information. And I welcome any questions.
Thank you, Dr. Amaral. That was wonderful. So we actually have about 2 minutes left, and I just want all the questions that we have to the people to know that after the session, the questions will be sent, I believe, and will be answered in a different format. So they will be answered. But I see a theme coming through about just what would, if you could talk just a few minutes about, are there immunosuppressant medications that are easier on kidneys than others, or what is the kind of prognosis? I think you did touch about it a little bit, but will all transplant patients see kidney damage because of their immunomeds?
Yeah, no, I don't think all will. I do think so. Tacrolimus is the biggest offender. But again, it's the best agent that we have, and we do have patients on it for many, many years. They may have some mild chronic kidney disease. There are other agents. There's something called Rapamune or sirolimus. It's an mTOR inhibitor. But every medicine has different side effects. So that one can cause protein in the urine. It can cause high cholesterol, mouth ulcers. There's even with CellCept, some patients have severe reactions. There's another medication called belatacept that we're going to be doing a clinical trial in very soon. That's an IV medication that people can get once a month. It replaces the tacrolimus, but you still have to take CellCept. So I think that risk really has to be individualized to your history and your family history, and what complications you've already had. So it's not one size fits all. But it's definitely worth discussing, what's best. And there are some once daily medications, some older generation medications. There are definitely things that we can try. But I think mild kidney disease is very likely. End stage kidney disease, again, only 3% of those patients over 20 years had that. So I think that's not very common. So you should be reassured by that. But, again, it's really important to do whatever you can to keep the kidneys healthy.
Thank you so much. Such good information. I learn every time I hear from you. So we hope everyone will join us, as the next session will be how to talk to peers about your transplant. That's a very big topic in our house, as I have two teenagers with kidney transplants who handle it completely different. So we hope that as this ends, you guys will, everybody who's on will join us for that session. Thank you again.
Thank you.